So now I do want to introduce, I have the most respect for Dr. Melin. Dr. Melin has a very busy practice. He's not only a wound care physician, but he's a vascular surgeon and lymphatic extraordinaire. Every time I listen to Dr. Melin, I learn something, and I want to tell you that we're going to learn about him and his product usage. So Dr. Melin.
Thank you, Frank. Yeah, very complimentary. I stopped doing vascular surgery about 4 years ago to focus purely on complex wounds, and I've been involved in wound care for about 22 years in a organized wound clinic fashion. So, thank you for your introduction. I want to thank you both for the opportunity to participate, and it's really a great opportunity to be beside the other two panelists and their expertise. I want to put all this within the scope of what's standard of care. So I don't think we can escape the fact that when we're talking about new technologies, like Frank said, we usually apply it to the most difficult, challenging cases that enter our clinics, and where a myriad of other things have been applied without resolution. And so I think when we look at these patients, it's always important to go back to basics. And so addressing things like tobacco use, diabetes care, hemoglobin A1C, offloading. In our clinic, total contact casting is the standard of care for application for plantar surface, and making sure there's adequate arterial blood flow. So getting ABIs, we do a lot of correlating duplex ultrasounds. Venous insufficiency evaluations to look for management of superficial venous insufficiency and management of venous hypertension. And then the one that tends to be overlooked, especially in lower extremities, is really near to Frank's heart, is lymphedema. And there's that phrase out there called phlebolymphodema, and we know that patients that come in with venous hypertension, 100% of them will have associated lymphedema that I think is under-recognized, under-treated. So I just want to put within the scope of care when these patients come in here and we're looking at products like Phoenix. It's with the understanding that we're doing all these other things first. And then the other thing that's near and dear to my heart is micronutrients. So are we doing things that maximize endothelial cell functionality? And it's recoupling nitric oxide production, which helps with immune system function, as well as maximizing arterial dilation and lymphatic function. So this is first case is the top of the skull. So this is a gentleman that had a radiated field after melanoma resection, recurrence, repeat Mohs, skin grafting, and then ended up with bone exposure. Now we had used other products just to get to this point. At one point it was probably a $50 size worth of bone exposure. So of course, MRI, make sure there's not significant underlying osteo. I took him to the operating room. We took care of the bone. We did ultrasonic debridement and really good wound bed prep principles. Now the middle three pictures look a little bit odd, and that's because we were using fluorescence imaging, so molecular imaging, to look for critical colonization, which would be defined as greater than 10 to the 4th colony forming units. Because that's the other thing, is you have significant biofilm, it can be difficult to get these wounds managed. So we know from peer-reviewed published data that most chronic wounds have a pH of 7.15 to 9. Skin mantle pH is 5.5. So this is what was one of the things that really attracted me to this product, besides my conversations with Frank and his clinical expertise and experience, was this unique ability to take a product that could very durable, easy to handle, easy to apply, well tolerated by patients, and has this ability to lower wound pH as it's interacting with the wound. So as we decrease wound pHs below 6 and back down to that acid mantle of 5.5, this is where we see a shift in the wound environment, decreasing that inflammation, and then maximizing angiogenesis through the resolution of inflammation and the resolution of the inflammatory components of high bacterial loads. So in the molecular images you see, we also can pick up on exposed bone. We can pick up on pseudomonas if there's a signing. The red or the proveridins will tell you about strep staph and various other microbial elements. So this is just showing us cutting this up. Very easy to cut this product, very easy to apply it, very easy to secure it. And durability, in addition to versatility, is the other really significant component. So we can put this on, and we would bring the patient back in during our initial trial every week to look at it. And oftentimes this product would be on for 2 weeks, if not a little bit longer than that. So the durability in terms of release of the product, I think, is really important and was helpful in this case. Next slide, please, Beth. Now, this is obviously a heel. This is a right leg. Again, standard of care would be application of total contact cast after ensuring that there's adequate arterial blood perfusion. And then in a diabetic like this, of course, that oftentimes has associated neuropathy, making sure we have really good cast application so we don't end up with secondary ulceration. So again, here are the markers. You can see in that second frame, that red is perviridins, which shows that we've got to do a better job of wound bed prep. So it allows us to do really good targeted application. But again, significant biofilm in this, even though it looks to the eye like it's pretty well prepped. So the thing I love about in this application is the durability of the product, knowing that we're going to get consistent driving down the wound pH and moderation of the inflammatory components inside of a total contact cast environment. And so to be able to then take the total contact cast off after a week and know that we're getting good moderation that entire week. So we're getting good offloading plus good wound bed management of that inflammatory component. I think this is would be a fascinating study to take, and this is something I'm going to ask Mike about as we're doing our Q&A. But taking a large, you could do it as a randomized controlled, you could do it as a retrospective, but looking at how does this function under total contact cast, and this could be a real accelerator for DFUs on the plantar surface. Next case, please. And then this is another complex case. So obviously we were using this in the toughest of the toughest. So this patient had a 5th metatarsal osteomyelitis. He's a kidney pancreas transplant, immunosuppressed, severe obesity, and there you can see a little bit of heme or blood running down after we had debrided based on the molecular imaging. So, but the fascinating thing around this, if you look at actually what's going around the wound, all that cyanine outside of the wound is all pseudomonas and hyperkeratotic tissue. So the other thing that molecular taught us was we got to treat the entire, not just the wound bed, but treat the entire foot. Get rid of all that hyperkeratotic tissue goes back to maximizing wound bed application. So here we have a markedly immunocompromised patient, diabetic, difficult, even though with his pancreas transplant, he's still having a little bit difficult controlling his numbers. And the durability to be able to put a total contact cast on in this point again and to be able to use it. Easy to apply, long durability, and versatility, and we get good outcomes in very, very difficult cases.